next session on partnership, as we were not able to keep Dr. Carol Presern, who was originally scheduled to moderate the session on acting in partnership, as she was unfortunately, her flight was rescheduled to become earlier than this specific session. While thanking the presence of Dr. Carol, respecting this meeting, I kindly call Dr. Kaseta Burhan Admasu, Chief Executive Officer of Rollback Malaria, to take this and the next sessions as well. Thank you so much. Please welcome.
Thank you, Dr. Ephraim. Good morning, everyone. So what I have learned from Geneva is, you have to all say, good morning, bonjour. Very good. It's really a pleasure to be back in Addis, and I would like to thank the organizers for inviting me to moderate this session. Information revolution is something that is really critical for global, national, and subnational development work. As all of you know, in everyday practice, data is generated at the community level, at the health facility level, collected, analyzed, managed at the district, regional, zonal, and national level. And global players look at various estimates, use different models, come up with how the world is making progress toward these mutually agreed goals and targets. But in the era of sustainable development goals, where we are emphasizing quality, equity, data is going to be really critical. I believe the world has done a lot in terms of making progress, and the low-hanging fruits in the area of maternal and child health and combating communicable diseases has already been tackled. The biggest challenge moving forward is to identify those members of communities that are not accessing basic services, that are not benefiting from the development work that all of us are striving to make a reality. So data that helps us to identify critical bottlenecks that put barriers and inhibit people from accessing and utilizing basic health services is going to be very instrumental. So when we talk about information revolution, when we prepared the health sector transformation plan in Ethiopia, one of the transformation agendas was information revolution. And in that preparation, we have consulted with a number of partners, global, national, subnational partners. And we basically landed on two important platforms that would help us transform information revolution. And I would presume this really holds for any setting, any context, and so on. The first part of it would be to have a mindset revolution. So data is generated at the health facility level by health workers through interaction between a health worker and a member of the community. So you really need to transform the mindset of our health workers in terms of, looking at the value of data. So a data that is collected for the sole purpose of reporting to higher authorities will not be a good data, will not help us transform health services, will not help us ensure equity and quality. Data that is collected with a mindset of using it on day-to-day practice to improve decision-making will help us achieve that goal. So we really have to give emphasis in making sure that our health workers value and appreciate the importance of data and continue to use it on day-to-day basis. Data for decision-making has been a buzzword for the last so many years, but the process of instilling this discipline, this appreciation amongst health workers needs to be really studied, and all of us need to work together towards achieving that. The second part of it is obviously the hardware, I started with the software, but the hardware is, laying out the systems, the processes, the standards, the norms, and the platforms, including the ICT infrastructure that will help us, collect data, relay it, analyze it on timely basis, and use it properly to respond to day-to-day, decisions. So we are really delighted to have an eminent panelist here. We have our first speaker would be Shri Manoj Jihani from India. Yeah? Oh, okay. Oh, so I'm sorry. It's, okay, I have to use the revised version, which is Dr. Ajay will be, Dr. Ajay Kera from Ministry of Health and Family Welfare, Government of India will be speaking. Dr. Ajay is a medical graduate with a postgraduate qualification in public health, and he has more than 25 years of experience in public health programs at national level. He is presently serving as a public health specialist and deputy commissioner for the Child and Adolescent Health Program in the Ministry of Health and Family Welfare, Government of India. Prior to this, Dr. Kera had as Assistant Director General and Technical Program Manager in National AIDS Control Organization, as Technical Manager in National Integrated Disease Surveillance Program. India has been a leader in terms of transforming data. So I really look forward to hearing your perspectives on how to revolutionize information to help us achieve our greater goals. Dr. Ajay, you have the floor. Yes, please.
Very good morning to all of you, and greetings on behalf of Ministry of Health, Government of India. And I would also like to thank the organizer for giving me this opportunity to talk about this important topic. Now, I have been given the responsibility to talk about the India experience in terms of data for action in the context of RMNCH program. Because in India, the MCH program, the so-called the Maternal and Child Health Program, is called as the RMNCH-A program, which is the Reproductive, Maternal, Newborn, Child, and the Adolescent Health Program. It is basically a life cycle approach. So what I'm trying to do is, I'm going to share, some of those India experience or the India learning in terms of using data for action, how we are trying to use the available data sets for improving the program performance, for program monitoring, for advocacy purpose, or even for the purpose of, trying to understand the impact of various interventions. Can I have the first slide? I have a few slides only. Can I have the slides? Can I have the slides? Yeah. Yeah, okay. Can we have the next slide, yeah? Now, basically, what I said was that RMNCH, programming, which has various elements, and the important elements are in terms of advocacy, or maybe in terms of program planning, or in terms of program monitoring, and also, measuring the impact of various interventions. And all these above elements, they depend heavily on the quality of the data sets. If we do not have the right kind of data sets, the decision making is not possible. And I think we all agree as a public health professional or as a kind of a program managers that unless data which are collected, they are appropriately used, the decision making cannot happen. And I continue to call, as a kind of, diagnostic tool to bring out a public health prescription. And in India, we are trying to use data in all the above stages and, make use of the appropriate technology also in terms of, data use. Next slide. Here. Now, these are some of those, kind of a data sets, which are being collected in the context of RMNCHA program. And one of the important data set is which is called as the, demographic health surveys. And in India, we call them the national survey. These are carried out periodically after a gap of 3 years, and they are a kind of rich data sets. And I will demonstrate to you that how we are trying to use the available NFHS data sets for the purpose of decision making. We also get some information on the something called as the sample registration system. We also get a very regular data sets through our system, which is called as the health management information system, which also provides rich data sets. And to my understanding, data becomes rich if you start using it. And if you don't use it, they don't become rich. And then we also have the supportive supervision monitoring tools which are available, which are real time. And then beside that, we also have a very specialized, kind of a data management tools which are called as the mother and child tracking systems. And even we have the special software which is called as the SNC Online, sick newborn data sets. And beside that, we have a special software which is called as the Electronic Vaccine Intelligence Network, which helps the decision maker in understanding the availability of the vaccines across the geographies of the country. And these are all real-time data sets. Next. Now, in terms of, the National Family Health Service, can I have the next slide? Now, in terms of, in terms of, those NFHS data sets which are being collected, what is being done is, we are trying to use these data sets to do the prioritization, to identify the geographies. We looked at the data sets, and we have in the country, we have 700 districts in the country. We have been able to identify 209 high priority districts, and we came up with a composite index. And these are the variety of the parameters, indicators which were used to bring out a composite index, so that we can prioritize our actions. So this is one example that, how we have used the National Family Health Survey data sets in terms of, prioritizing. And it is not only prioritizing, both in terms of, extra funding and also in terms of, better technical assistance with the help of development partners. Next slide. Now, similarly, we have tried to use the available health management information system. Now, with this available data sets, which is being collected from more than 100,000 facilities in the country, across the country, and we have tried to bring out a scorecard. I think since yesterday we have been talking about scorecard, so we have really converted them into a scorecard, and these scorecards are available to understand the situation even at the block level. So that means at the district level, the district chief comes to know that where is the problem, not only in terms of geography, also in terms of the kind of the intervention, whether there is a weakness in the maternal health or there is a weakness in the child health interventions. Next. Now, similarly, we have the concurrent mechanism in terms of supportive supervision. Again, the different facilities are being visited, and those data sets are being captured regularly using a standard kind of a checklist. Next. And then this is the kind of the improvement which is found by the supportive supervision, that we could find change while doing a supportive supervision. We could find the improvement in the availability of the services, availability of the equipment, availability of the trained people. We can demonstrate a change. Next slide. Now, similarly, we also have the variety of data solutions, which I told you, like SNC Online, we have the Anmol for the ANM, and we also have the Electronic Vaccine Intelligence Network. Next. Yeah. So this is just a kind of a snapshot of variety of the tools which are available, which are helping. Next. Next slide. Now, this is the kind of the last slide which tries to capture the kind of the new thoughts which have been incorporated in the RMNCH programming, and different data-driven kind of tools which have been put into operations are in terms of stillbirth surveillance. Then we have the mother and child death audits, and then the comprehensive nutritional biomarker survey, birth defect surveillance system, and even the community need assessment, facility assessment surveys, and even the rapid coverage evaluation survey. So we are trying to use all these kind of a survey data to improve the program performance. And only then we should be able to reach our so-called the goal of sustainable development goal of ending preventable maternal and child deaths. So this is the way in India there are different kind of approaches are being used. So with these few words, I stop here, and thank you very much.
monitoring and evaluation. Formerly the Vice President of the International Division of JSI, he currently is Project Director of the Data Use Partnership in Ethiopia. His specific area of strength and focus in the last 25 years has been the